I would like to invite Dr. Anukaran Mahajan from Amistad to the stage. He will speak on the sleep lab revolution, polysomnography, and sleep evaluation devices.
Good morning, everyone. Sorry for the delay. First of all, I congratulate Dr. Shankara Subramaniam for organizing this wonderful conference. I'll be talking on the sleep lab revolution. So, a brief history of the sleep. So, first was the era where sleep was considered a passive state. For centuries, sleep was viewed simply as the absence of wakefulness. Ancient physicians believed sleep occurred because blood or body heat shifted away from the brain. There was no concept of different sleep stages or sleep disorders. It was just merely an absence of wakefulness. This changed in 1920s when Hans Berger introduced human EEG, and it was the first physiological recordings which showed that the brain is switched on during the sleep also. This was the first technological foundation of the modern sleep labs. Then, in 1937, the first sleep classification was given by Loomis et al. Later on, in 1953, REM sleep was discovered. A landmark discovery came in 1968 when Alan Rexheffen and Anthony Cales provided the world with R&K manual. This was the first rule book of sleep medicine, and it remained global standard for 39 years when in 2007 the American Academy of Sleep Medicine gave its own manual. Again, after that, in 1970, Stanford Medicine developed its first sleep lab under Dr. William Dement. Then, in 1976, Guillemot coined the term obstructive sleep apnea syndrome. Then again, in 1970s, he and Dement devised the apnea-hypopnea index, and also he was the first one to describe the pediatric sleep apneas and also the concept of upper airway respiratory syndrome. In 1981, Colin Sullivan described the world's first CPAP, and he still remains active in teaching about the same. Then in 2007, American Academy of Sleep Medicine gave its scoring manual for sleep stages, where they defined apneas, hypopneas, the apnea-hypopnea index, and sleep stages, etc. The entire things changed in 1990s when we shifted from the paper concept to more of a digital era and computerized concept. In 2010, the home devices like Watchpad became popular. The guidelines of AASM were revised in 2017, and in present state we are at the cloud and wearables and the AI coming into picture. So to talk about sleep studies, there are grossly 4 types of sleep studies. The level 1, a level 2, a level 3, and level 4. Level 1 sleep study is the gold standard sleep study. So what does a level 1 sleep study incorporate? It has multiple channels like the electroencephalogram, the electromyogram, the electrooculogram, position sensors, respiratory inductive plethysmography belt, electrocardiogram, nasal pressure transducer to detect the nasal airflow, and pulse oximetry. The most important thing is that this all is done under a continuous technician supervision and an audiovisual recording. Apart from it, other parameters like core body temperature, EtCO2, transcutaneous carbon dioxide monitoring, or endoesophageal pressure probes are also there, but they are more for research purpose rather than clinical conduit. Clinically speaking, a level 1 polysomnography will include all these sensors, along with the most important thing being that this is done under a technician supervision. A technician is present throughout the night near the console to monitor what is going on in the real time. A typical polysomnography report or a level 1 sleep study report will look something like this, which will have a lot of parameters including the sleep architecture, respiratory data, respiratory event, the arousal events, limb movements, oxygen saturation distributions, and an all-night hypnogram which will include all these parameters compiled into a single graph. We can sometime also go for a split night study where the first half is used for the diagnostic part, and the second half is used for the therapeutic part, wherein we put in on a pressure device, maybe a CPAP or a BiPAP, and see what is the change in the parameters. Are the apneas and hypopneas being resolved, or they are still being persisted, or at what pressure are these being resolved? And in-lab polysomnography, indications are immense. We'll not go into detail about them, but shortly speaking, a level 1 polysomnography can be used to detect almost every sleep disorder that is out there. Be it sleep-related breathing disorders, be it sleep-related neuromuscular disorders, maybe for PAP titration, maybe before the sleep apnea surgery, maybe for nocturnal epilepsy, maybe for REM sleep behavior disorders or whatnot. There is rarely a sleep disorder which cannot be diagnosed with a polysomnography level 1. The indications where it is not, the points where it is not indicated includes parasomnias, insomnias, circadian rhythm disorders, and other common sleep events like bruxism, nightmares, and sleep talking. And a relative contraindication is a moderate severe OSA, where a level 3 sleep study is comparatively cheaper variant to provide almost accurate data as a level 1 polysomnography. The drawbacks of level polysomnography are there, definitely. The first and foremost being a high cost. A level 1 polysomnography requires specialized equipment, trained staff, and overnight monitoring in a sleep lab. This becomes costly both for the patient and the healthcare system. The second being limited accessibility. Still, in a country like India, the sleep labs are not widely available. Even in countries outside India, the Western so-called advanced countries have a dearth of these sleep labs. The third being a first night effect. Since the patient is coming onto the sleep lab or a hospital setup, changing the environment can lead to atypical sleeping patterns, and which can lead to drawbacks in the accuracy of the result. The fourth being, this is a one night snapshot. A polysomnography includes the data of only one night, while there can be day-to-day variabilities during everyone's sleep. So a single night's data is sometimes not very accurate to detect what exactly is going on in the patient's sleep. And the last being patient discomfort. Since there are multiple sensors connected to the patient, these can cause some discomfort leading to frequent awakenings, and he may not be able to achieve a normal sleep architecture under these conditions. So when we talk about level 1 sleep study, there is another study that is called a level 2 sleep study. It is almost the same as a level 1 sleep study, but it has certain parameters which are moved out of it. There is no audiovisual recording, there is no technician supervision. Rest of the parameters and the channels remain the same as a level 1 sleep study. The more important comparison is with a level 3 sleep study, which is also called as a home sleep apnea testing. So a level 3 sleep study will typically have a position sensor, a plethysmography belt, an ECG, a nasal pressure transducer, and a pulse oximeter. So with these minimum channels, the level 3 sleep study can detect the most common cause of sleep disorders, which is the obstructive sleep apnea. The indication of a level 3 sleep study is typically an uncomplicated, moderate to severe obstructive sleep apnea. This is the only indication of a level 3 sleep study. There is no other indication where a level 3 sleep study will suffice. How do you define an uncomplicated sleep apnea? First, there should be an absence of increased risk of central apneas or sleep-related hypoxemias. Secondly, there should be absence of significant cardiopulmonary risk or history of stroke or chronic opioid use. And thirdly, absence of non-respiratory sleep disorders, example central hypersomnolence, parasomnias, or sleep-related movement disorders. So, when is level 3 sleep study not recommended? First, when the patient is having significant cardiorespiratory distress. We all know that obstructive sleep apnea can lead to significant cardiorespiratory distress. So if a patient has already developed significant cardiorespiratory disease, the patient should be indicated towards a level 1 sleep study rather than a level 3 home sleep apnea testing. Secondly, in patients with potential respiratory muscle weakness due to neuromuscular conditions, we see neurologists referring us patients for sleep apnea testing. Again, for such patients, a level 1 sleep study is only indicated. A level 3 sleep study will not do justice. Thirdly, a patient having with awake hypoventilation, or like we have obstructive obesity-related hypoventilation syndromes. In such patients, again, a level 3 sleep study will not do justice to the depth of disease that the patient is having, because a level 3 sleep study often underestimates the risk. Similar is true for a patient on chronic opioid medicines or a patient having history of stroke or severe insomnia. But there are some advantages with a level 3 sleep study. These include that there is accuracy of diagnosing the results is similar to a level 1 sleep study in uncomplicated moderate to severe OSA. This term has to be very importantly registered in everyone's mind that level 3 sleep study is only for uncomplicated moderate to severe sleep apneic suspected patient. Of course, it is less costly, it is more comfortable, and there is increased access to the testing. Since it is done in the home itself, there is elimination of the first night effect. When we compare a level 3 sleep study with a level 1 sleep study, the differences become very clear. Talking about the accuracy of diagnosing the uncomplicated moderate to severe sleep apnea, both level 1 and level 3 will do well. But if we talk about accuracy of diagnosing a complicated sleep apnea or a mild sleep apnea, a level 1 sleep study will definitely be preferred over a level 3 sleep study. The cost of equipment, definitely level 1 is much costlier than a level 3 sleep study. When we talk about convenience or comfort to the patient, level 3 sleep study scores better than a level 1 sleep study because of much less sensors in it. The first night effect leading to distortion of the architecture and normal sleep is present in a level 1 sleep study while it is eliminated in a level 3 sleep study. Risk of data loss or device failure or due to lead disconnection is not there in a level 1 sleep study because a technician is throughoutly observing the data. The moment a lead is disconnected, the technician can just put it back on. But since in a home sleep apnea testing, there is no technician supervision, sometimes the data is lost just 2 hours within the test. So the accuracy of that test goes away. We have to repeat the test on another night. And in a patient who is having fragmented sleep or easy arousability, again, a level 1 sleep study can only accurately diagnose the sleep apnea. A level 3 sleep study will fail. We'll just see this with an example. Consider a patient who is having fragmented sleep and easy arousability. He slept at 10 p.m. and woke up at 3 a.m. According to a level 3 sleep study, which records the denominator of apnea-hypopnea index as the total recording time. The patient is having, let's say, 40 episodes of apnea and sleep apnea. His AHI will turn out to be 8. This falls under mild sleep apnea. But in reality, what happened was the patient slept at 10 p.m., went to bed at 10 p.m., slept at 11 p.m., woke up again at 12 a.m., again slept at 1 a.m. and woke up at 2 a.m. Throughout its recording time, his actual sleep time was only 2 hours. So what will be his apnea-hypopnea index as per a level 1 sleep study? It will be the total sleep time as per the EEG recording. So his total apnea-hypopnea index will change from 8 to 20, changing his diagnosis from a mild OSA to a moderate OSA. So that is why in a patient with fragmented sleep or easy arousability, a level 3 sleep study or a home sleep apnea testing is not recommended. So these are the key differences between a level 1 and level 3 sleep study. I think we have discussed all of them already. Coming on to the level 4 sleep studies, this is basically just a pulse oximetry with or without a nasal airflow pressure transducer. Where does a level 4 sleep study stand in today's era? It is merely a screening tool. The American Academy of Sleep Medicine does not recommend it for diagnosing obstructive sleep apneas. This is grossly a chart comparing the level 1, level 2, level 3 and level 4 sleep studies. I think we have already gone through it. Because of shortage on time, we will not discuss this. Coming on to the type of sleep studies, we can also have an overnight sleep study which is purely diagnostic. We can have a 2-night study where the first night is used for the diagnosis part and the second night is used for the titration part. Or we can have a split night study where the first half of the night, same night, is used for the diagnosis and the second half is used for CPAP titration. There is a certain criteria that has to be followed for doing a split night study. This strict criteria is that while doing the diagnostic part, there should be at least the recording should be for minimum of 2 hours and there should be a diagnosis of at least moderate to severe obstructive sleep apnea in those initial 2 hours diagnostic period. Only then we can put the patient on the second half CPAP titration. Again, for the CPAP titration to be validated, the score, it should be for more than 3 hours. The patient should be free from the apneas using a CPAP in the supine position in its REM sleep. Unless and until a patient is able to achieve REM sleep and supine position and elimination of apneas, that CPAP titration is not considered to be valid. So the split night study in such cases is a failure, and we will have to go back to a 2-night study. So beyond the sleep lab, we have now evolved to other home-based apnea testing also, like home sleep studies, watch pad, consumer wearables, contactless wearables, AI, and cloud-based systems. One of the most interesting event in technologies that has happened is a watch pad. So a company started to think out of the box, and they diagnosed, what if we could diagnose sleep apnea without measuring the airflow at all? We all know that there is a physiological cascade that occurs when apnea or hypopnea index happens. Whenever there is an airway obstruction, there is increase in respiratory effort, which results in hypoxia and hypercapnia, which leads into cortical and subcortical arousals, which leads to sympathetic activation, which is catecholamine surge and tachycardia, and this leads to a peripheral alpha adrenergic vasoconstriction, and this is what the watchpad measures. The algorithm makes a respiratory event retrospectively in real time. So these are the components of the hardware and all the outputs that are detected with the watchpad. They are using the denominator as a total sleep time rather than total recording time, which makes it much more accurate than the level 3 sleep study, also being much more comfortable than a level 1 sleep study. The recent studies have compared a watchpad and level 3 sleep study along with the level 1 sleep study, and they have found that watchpad's accuracy is at nearly 98% of a level 1 sleep study, which is talking very highly of it. Apart from it, there are other devices like Apple Watch, Aura Ring, Whoop devices, Fitbits, the Samsung wearables. All these devices, they have excess amount of data, but again, they are still not being medically validated to accurately detect the results. Their role is definitely, in future, is definitely going to increase because a lot of research is being poured into sleep diagnostics. But as such, of present time, again, American Academy of Sleep Medicine does not recommend any of these devices to diagnose sleep health. The future lies with contactless room measured sleep parameters like UV-based, radar-based sensors, mattress sensors, camera-based sensors, which incorporate the AI, smart textiles, and acoustic monitorings. Apart from it, there are some sleep questionnaires like Epworth Sleepiness Scale, the Berlin questionnaire, Stop Bank score, which can detect the results. Other tests like multiple sleep latency test, maintenance of wakefulness test, and actigraphy can also be used to diagnose sleep health disorders. To summarize, sleep studies have evolved from its nascent stage and are still evolving into routine health measurement parameter. These studies assess sleep architecture, they monitor breathing patterns and movement disorders. A level 1 sleep study is the gold standard. A level 3 sleep study is an affordable, accessible, convenient, and accurate alternative in a certain set of patients. A level 4 sleep study is not recommended, and it is merely a screening tool. As a sleep specialist, consider this as a sign to get your own sleep study done. You will get to know how a sleep patient feels while undergoing a polysomnography. You will be able to connect with your patients better. I thank you all for your patient listening. And with this, I invite you all to Amritsar, my hometown. We are holding the National Conference of Indian Society of Otology on 9th, 10th, and 11th of October. I heartily extend my invitation to all of you. Thank you.
Thank you for a very comprehensive and well-structured presentation, Doctor. Your presentation clearly emphasized it's not just merely conducting the test, how we interpret the test and how we clinically correlate the findings.
Yes.
Thank you, Doctor.
Wonderful presentation, sir.
Thank you.
And you clearly explained about the type, level 1, level 2, level 3 studies and level 4 studies, and what are the recent things and which is recommended and which is not recommended. Excellent.
Thank you.
Thank you, Doctor. Now I request the chairpersons to the stage.